Hello again, everyone, and welcome to today's webinar on Nursing's Time of Truth, Reckoning, and Transformation by Dr. Katie Boston-Leary. I'm Michelle Bowditch, AMN Healthcare Senior Specialist for Executive and Aspiring Leader Programs. And as a reminder, nurses attending today's education will receive 1 CE credit. We will have access to all those who have attended today, and a post-course evaluation must be completed to obtain your statement of credit. Please note that your CE certificate will be issued by rn.com. If you experience any technical difficulties during the program, please use the chat pod to communicate with our technical team. These messages are monitored and will be responded back to you as soon as we can, or you can always contact us at educationsolutions@amnhealthcare.com. At the conclusion of the webinar, there will be a question and answer session, and our presenter will take your questions at that time. After Q&A, I will conclude the webinar by providing information on how to obtain your CE credit. And now to introduce our esteemed guest presenter today is Dr. Cole Edmondson. Dr. Cole has a career spanning 2 decades with roles including clinical nurse, supervisor, manager, director, associate chief nursing officer, 3 chief nursing officer positions, and his current position as chief clinical officer at AMN Healthcare. He is a fellow of the American Academy for Nursing and the American College of Healthcare Executives and Nursing Executive Advanced Board Certified by ANCC. He is a Robert Wood Johnson Foundation Executive Nurse Fellow alum. Dr. Edmondson is a contributor to the literature and speaker locally, nationally, in the area of leadership, succession planning, research, moral courage, nurse bullying, culture building, emerging global health issues, and Magnet. He is a co-creator of www.stopbullyingtoolkit.org, where they provide a comprehensive site and links to resources, blogs, stories of both bullying and heroes, and campaigns for an end to this problem in nursing and healthcare. So I'll go ahead and turn it over to you, Dr. Cole.
Thank you, Michelle, and thank you to the team at AMN that has put this together. What an honor to be here with you all today, and thank you for joining us at this AMN for this webinar. It's my absolute pleasure to introduce our incredible colleague and friend who inspires me every day, Dr. Katie Boston-Leary. Katie is the director of the nursing programs at the American Nurses Association, overseeing the nursing practice and work environment division, as well as Healthy Nurse, Healthy Nation. She is also a co-lead for Project First Line, a multi-million-dollar grant collaborative with the CDC for training on infection prevention and control. Katie is also the co-chair for the DEI committee for the Health Leaders Network Delaware Valley, which is an ACHE affiliate. She also leads a nonprofit, the REACH Initiative, that provides executive coaching to healthcare leaders with a focus on providing pro bono services to BIPOC nurses. Katie is an adjunct professor at the University of Maryland School of Nursing and the School of Nursing at Case Western University. She is a board member on St. John's University's health programs, the George Washington University Women in Business program, and an editorial board member of the WebMD Medscape. She is also a member of the National Academy of Medicine's Action Collaborative on Clinician Wellbeing and Resilience, sponsored by the U.S. Surgeon General. Her most recent research was a qualitative study on nurses' perceptions of power dynamics in hospitals. She is a well-known speaker nationally and internationally, with many publications and podcast guest invitations. She completed her PhD at Walden University in Health Services, obtained a dual degree MBA and MHA from the University of Maryland Global Campus. She is a board-certified nurse executive and obtained a nurse executive leadership certificate from the Wharton School of Business. She has been interviewed for stories in numerous print, online, and television media outlets and has authored numerous articles on racism, DEI, well-being, and other challenges in nursing and healthcare. In fact, you may have seen her this morning on the Today Show discussing the nursing shortage and the way nurses want to work today. Dr. Boston-Leary, thank you for being here, and the time is yours.
Thank you, Dr. Edmondson. I'll turn my camera on so you can see me. Hello, everyone. What an honor to be here tonight. And Dr. Edmondson, thank you so much for that introduction. I'd like to also extend my thanks to the AMN team for having me. Really, really excited to be with you all tonight. And I really appreciate you taking the time to listen to me. It's towards the evening where I am. I know a number of you are in different time zones. So wherever you are, I'm grateful. So thank you, and I will get my slides up in a second so we can get started. So this is a discussion that I want to set up using the Truth, Reckoning, and Transformation framework that really sets up pretty much a pivotal point that we are in the nursing profession. Where do we go from here? What are the things that are holding us back? How do we move forward? What are we missing the boat on? What are the things that we know we need to fix, but we can't move forward on? But also add in some elements of diversity, equity, inclusion, and some of our past history regarding racism in nursing, implicit bias, and all the other pieces related to social justice, because we want to make sure that we start changing the minds or informing our nurse colleagues that a lot of what we see in society doesn't sit outside of nursing. It's very much playing in the profession. What we see sometimes in the profession is a microcosm of what's happening in society. So that's going to be the discussion today. And it's not to set up a belief that things are hopeless. We have a lot of hope. There are a number of things that we can do to move the dial or to point our toes in the right direction. So I hope you enjoyed this presentation, and hopefully it's illuminating. And I look forward to your questions at the end. So here are my written objectives, where we're going to look at nursing and the history of nursing and the role of the history and how it impacts our understanding of where we are today, and looking for new paradigms to move forward. Learning and appreciating nursing as a profession and how it began, to pretty much awaken our advocacy spirit. Learning about the significance of the scope and standards impact on practice, and understanding the importance of psychological safety for respectful and equitable practice. Analyzing the role and impact of structural and systemic racism that creates and maintains health inequity and inequality. And last, advancing an anti-racist practice climate in nursing, which is going to lift us all, right? Not just our patients, but us as care deliverers, and the role that we play in righting the ship as it relates to disparities in health. So Dr. Edmondson did go over some of what I do at ANA. This is just a quick snapshot that understates what I do, but I do oversee nursing practice and work environments. The umbrella department is nursing programs. I oversee Healthy Nurse, Healthy Nation. I do some work in nurse abuse and workplace violence. We have a nurse staffing think tank, and I will share some of the recommendations from the think tank that has concluded, but now we have a task force that's starting to work on some of the perennial issues. That's co-mentioned Project First Line, which is a multi-million-dollar grant with the CDC for to provide free infection prevention and control resources to nurses and everyone in nursing. Safe Patient Handling and Mobility, we produced a new book on that, a second edition that I invite you all to look into and purchase. Well, we're setting up a culture of safety, physical safety. The Minority Fellowship Program, and I manage the interprofessional, interdisciplinary version of it, where we have a nursing, social work, psychology arm to address mental health in underserved communities, and do some research there and support scholars at the master's and doctorate level to conduct research and do some work in these communities that have been long neglected as it relates to mental health and well-being. And then I proudly say that I'm a part and work within the National Commission to Address Racism in Nursing, which is the commission that we set up on the heels of the murder of George Floyd. and has really accomplished a number of things. So all these are on our nursingworld.org site. Please feel free to check it out so you can learn more about all these different things. So as I mentioned earlier, the framework for my discussion is around truth reckoning and transformation. Everyone knows about apartheid in South Africa. And this is a framework that was utilized in South Africa to reckon with a lot of the past ills and harms to people of color in that part of the world. Desmond Tutu, both these gentlemen have since passed on, the late Nelson Mandela and the late Archbishop Desmond Tutu. Desmond Tutu led the transformation, the TRT Commission in South Africa in 1995. And that was a forum that was set up for people to, particularly victims, because it was really a somewhat balanced or imbalanced commission to hear from victims and perpetrators. And it provided a forum for victims to share what they went through during apartheid and in very stark terms, in a very public way that they've not been able to do. And that catharsis leads hopefully to healing. But the reconciliation part is the hardest part in this equation, because it does give a sense of kumbaya, which is not what we want to do, or dismissing of the mending and the healing that has to happen before you get to transformation. But at least it's something that provides free space and room for stories to be told. And we've heard some of that in nursing, which is what you hear later on in my slide deck from nurses of color that have really been harmed, some cases intentional, some intentional. And we had listening sessions where they were able to do just that. And we continue to hear their stories. So let's start with the truth, right? The brutal truth that we need to confront. In 1873, nurses were very much steeped in advocacy efforts and politics. And it's interesting because we hear today some nurses say, oh, I don't want to do a politics. It has nothing to do with healthcare nursing. I beg to differ. And we were actually founded in that space. And this is a space that we need to embrace, particularly where we are as a nation. This is an image of the nurses marching during the suffrage movement in 1873. And here's some perspective around that time. Nurses took charge of their own personal and professional lives as a group, as a body. In asserting their independence, many nurses supported the women's suffrage movement, as I mentioned earlier, and fulfilled the mission of the social feminists in the late 19th century. There is also a book that and some writing that I encourage you all to read, that really speaks about the professional growth of the trained nurse, who replaced the natural-born nurse following opening of nursing schools in 1873. There still is that belief in some parts of the world and in some communities, even here in the U.S., that there are tendencies that particularly women are born with that could qualify them to be a nurse. And we had to do some work for us to prove that this is the profession. And we continue to work on the image of nursing. We know that in social media, and even if you did a Google image search for a nurse, or if you looked at your gifts and you try to do a search and typed in nurse, you'll see some very unflattering images of nursing or of nurses that are set in beyond times that we should not be seeing today. We also want to identify during this time that, as I mentioned earlier, any woman could be called a nurse. And it was actually deemed as women that nobody wanted, right? The spinsters, the widows, someone that also didn't have a good reputation in the community. And that's part of what we've had to change over the years. And it's good to look back at history to see where we've come from. And then you also see that the devastating effects of overcrowding, poverty, and questionable sanitary practices, which happened back then, really help reform the movements that we see today. So proud that we have been seen for the last 20 years by the Gallup survey as the most trusted profession, but we have some work to do for us to be seen as the most respected profession. We also want to make sure that there's understanding that nurses had and still have political punch and power. We have nurses on the Hill that are doing some really great work, that are making their presence known. And we want to continue to build on that, right? And we have a number of organizations that are supporting efforts to get more nurses in the legislative space, because that's where we start changing some of these rules and laws. But it's important to also understand that, especially if you look at this, you think we're well past this, right? No, I can add another sentence here about what we have just seen with the Supreme Court ruling about abortion rights, right? And GYN health. So this work is still continuing, and it's work that we should all own as nurses to continue. So to speak to what happened back then in yonder years, but it's not that long ago, because it's still captured in history. I hope everyone here knows about Mary Eliza Mahoney, who was the first African-American nurse to graduate from nursing school. She practiced, learned to practice in a hospital. She was one of the first Black Americans to become a part of ANA, particularly with the dissolution of the NACGN, the Colored Graduate Nurses Association. And she was a force to be reckoned with, where she did not just finish her program and went into the community to start working. She continued her advocacy efforts on behalf of nurses of color, particularly Black nurses. Unfortunately, with Mary Mahoney's experience, where she learned how to be a nurse in a hospital, after she finished her program, she was never able to practice in a hospital. Hospitals were reserved at that time for nurses, for white nurses. So Black nurses had to work in communities for lesser pay and were seen as servants. Mary Mahoney was a proud nurse, and she wanted to continue to distinguish herself as a professional. And one of the stories that I've read about her is that even though she was seen as the help, and she was given less pay and all that you expect to see when you're considered to be the help, she proudly made sure that she sat in a separate place to eat her meals apart from the help that was truly hired in that role, because she insisted on being seen as a nurse. And how unfortunate during that time that even though Mary Mahoney trained to become a nurse in a hospital, she was never able to step foot in the hospital to practice. And I'll say the only time she was able to go back into a hospital was when she was dying of ovarian cancer. So thankfully, Phi Eta Chi, which is one of the oldest, or I'll say the oldest Black Nurses Association, helped with finding the marker where she was buried, and work with the ANA to set up a tombstone, so at least we have a place to mark where she was buried. And this proud woman, also with all of her financial strife and everything else, her main thing that was really important to her was to buy burial plots for Black Americans that cannot afford. And she made sure she saved money for her own burial plot when she got to that point. So this is another story in history about the confrontation that was occurring with Black nurses, where they felt that they were excluded. They weren't being welcomed into the ANA as a respectable body. And as much as they worked to try to find some respect and regard in communities, they still earned low pay. And it was a struggle where and if you talk about some of the principles around belonging, they were seeking that was not coming to them. They wanted to be a part of caring for soldiers as well. That became an issue where they had to fight really hard, and there was a slow trickle of allowing Black nurses to care for soldiers that were injured in war. But the key thing here, when we talk about the liberation that occurred in the North compared to the South, even in the North, where a lot of nurses, where Mary Mahoney was born in Massachusetts, where it was considered to be somewhat free, there were still restrictions for nurses to be able to practice freely. So you see here about where it talks about the salary difference that tends to occur. And even with caring for patients, there was a struggle with Black nurses doing education and teaching, which is the bane of what we do as nurses, on how to breastfeed their babies. And it was seen as a position that Black nurses should not be in with white patients. So that was part of what was considered with the exclusion that happened back then. One of the last things I'll mention, and I'll pause on the history here and go to where we are today, but I'm going to come back to the pretty much how we went full circle with what happened back in 1951, where there were two boards of the ANA and NACGN, and I mentioned that there was a decision to integrate. But there was a concern about in 1951 from stoppers that this was a leap of great faith to integrate these two organizations. So I'll come to some of what was determined and what happened and where we are with some of the reconciliation work that we did at ANA to right some of our wrongs with what was promised in 1946 and 51. So the revised definition of nursing that we have in the ANA Scopes and Standards 4th edition is here in front of you. And it really highlights some of the things that we should be focusing on as nurses, where we're integrating the art and science of caring. We are really honing in on human functioning. And I like to add also that we are supporting human flourishing. Compassionate presence is required as well for what we do for our patients. And also recognizing all humanity, right? And there's mattering with every single person on this earth. And it's not based on where they're from, who they love, their socioeconomic status, and anything else that makes them different from the eyes of the beholder. The Code of Ethics also sets up what we should be doing as nurses, where it's really about understanding our obligation for all nurses to be allies and advocate for and speak up against racism, discrimination, and injustice. There is public comment. I think the public comment period is still open for a Code of Ethics language around racial discrimination and inequity. So I encourage you all to check it out because we want your opinions, because that will be coming out soon as well. But what we want to continue to emphasize that I mentioned earlier, I went too fast, is that nursing is part of society. And I always have to say this because in some circles in the public arena, there is a belief that nurses are protected from what's happening in society. We saw some of that during the pandemic, where it was be here to heal us, support us when we come for care, but nurses were struggling with their own families, with their own situations, with protecting their families as well. So nurses, and I continue to say this, and it's sad that I have to say this year, but in 2022, but nurses don't live in hospitals, they don't live in communes, they're not all female, they come from all walks of society. And we have to continue to emphasize that we see the good and the bad, and we experience both as well. During the social injustice discussions, you talk about how, with George Floyd, how Black mothers were very protective and fathers were fearful for their sons when they were driving. Those Black mothers and fathers are our nurses too. So we need to be reminded of the fact that some of the injustices that we see that's happening in society with gay rights, LGBTQ, and all those different pieces are affecting our nurses too. And they have to show up for work to show that compassionate presence, which is hard and challenging when you have to think about protecting your loved ones as well. So hopefully you're familiar with the Future of Nursing report, which was the next 10-year report on charting the path to where nursing should be. A lot of focus in the new Future of Nursing report on the charting a path to achieve health equity. Health equity is mentioned many times in this report compared to the old version from 2010 to 2020, where it was really a heavy focus on the academic progression of nurses. Now this focus is really on how we right the ship with really making sure that we achieve our goals with health equity and dismantling structures that continue to make this the case and prevalent in how we deliver care. So you see around the social determinants of health, which is the word we've used over the past 5 years, or past few years, we have not made the inroads that we would like to make. And during the pandemic, we saw a lot, but we saw enough in terms of the inequities that exist, the environmental injustice issues that exist, the issues that we see with transportation and access. So you see it all here, right? It's a public safety piece, right, with not being able to drive safely. Physical environment, where are people going when they go home after their discharge to stay well? social environment that they live in. Can they safely walk to the bus or to their cars without being worried about being shot or robbed? The education systems, we've seen the disparities there with some communities, the underserved communities compared to more affluent communities. Transportation issues, where we heard stories which we never even thought about, where bridges are set to a certain height so large buses will get through so that it can prevent certain people from getting to certain parts of the country. Housing, it's important for us to understand that piece as well, the redlining that occurs where only so many people based on their income can live in certain places. Employment, health systems and services, all of those pieces, income and wealth, these are all contributors to what we see with the social determinants of health. It's not just around, you're a certain color and you're predisposed for certain illnesses, so let's see how we can mitigate these issues because of your race. We have to look at the whole, and that's what this is depicting. The vision is that the systems that we set up in terms of our health systems needs to permanently remove barriers, to value nurses' contributions. There's a lot of talk around nurses seen as an expense versus a contributor to revenue, preparing nurses to advance equity. And every single nurse, not just our case managers or folks that are in social work, every single nurse should have a strategy to advance equity in health, in delivering health to all communities. And also diversifying the workforce, which is important to achieve Goal 3. This is just a picture of some of the diversity concerns that we have in the profession. And this is a bar graph of nurse practitioners, but these numbers are not that different from what we see with nurses. And unfortunately, when you look at these numbers from 2018 to 2008, we're not making the improvements that we'll like to make with diversifying the workforce. So we have a lot of work to do here. And when we think about how we are in the globalized economy, you have to ask the question, what gets in the way for us to move the bars up a little higher with our Hispanic, Black, and African American, Asian, and I hate the word other, but all the other groups that are not listed here, AAPI, and I know Asian is not a good category because it does that monolith as well. And same for Black Americans. Not all Black Americans have the same descendants. So we have to really think about how we divide these categories respectfully and honor the ethnic backgrounds of all people. But most importantly, we have to diversify this workforce for us to achieve health equity. Also seeing here about racial and ethnic minorities account for 40% of the population, but only 20% of the workforce. So again, shows that this is under that umbrella discussion around mirroring the communities that we care for. And we have to do that for us to be able to make the inroads that we want to in terms of health equity. So this is a reckoning phase of the discussion. And this is where I get to share some of the things that we've faced with our commission and some of the reckoning work that's happened since we uprighted the commission in 2021. The commission includes some key nursing associations for nurses of color. But at the helm, we have, of course, ANA, the National Black Nurses Association, which was formed after they felt that the ANA was not meeting the needs from the dissolution of the NCGNA, the National Coalition of Minority Nurse Associations, NCEMA, and the National Association of Hispanic Nurses. This is a list of other participating organizations that are a part of the commission. As you can see here, we not only have minority organizations for nursing, but we have other associations as well, like AONL and a number of other key organizations that we feel should be a part of this work that has been very engaged and very involved in getting us to where we are with what we've been able to accomplish as a commission. This is a definition of racism that the commission was able to develop, and there was a lot of time that was spent to make sure we got it right, because we felt that the definition that existed for racism did not fit the group that we were talking to. It wasn't fitting for our audience. So like what nurses do, we decided to craft our own definition. Like when we don't like what we have, we build our own. So that's what we did. And the definition is assaults on the human spirit in the form of actions, biases, prejudices, and an ideology of superiority based on race that persistently causes moral suffering and physical harm of individuals and perpetuates systemic injustices and inequities. The listening sessions, I mentioned earlier about the process in South Africa when they had the reckoning piece where people came to the table and shared their suffering. This is what we heard from nurses of color when we hosted 4 sessions to hear from them about what they've experienced as nurses of color. Now, when we set these up, we did not say we only wanted to hear from nurses of color. We did an open call for anyone to be a part of these discussions. And what you see on your screen are some of the verbatim statements from people that participated in these listening sessions. I also want to caution you that some of what you're going to see on your screen is triggering, and it's also recent. You can see at the bottom that these were conducted in June of 2021. So when you read some of these, you'll think that some of these statements were made in the civil rights era, and unfortunately, that is not the case. One that I'll read is, if I were to replace my face with a white person's face, where would my career be? And we heard a lot about careers being halted and growth being stunted because of some of the dynamics that we've seen with racism and structural racism playing a part, particularly in the academic setting. Here's more in terms of the impact of racism on health and well-being for nurses of color. You see here, racism has affected my well-being with having to take a leave of absence from a job in 2008 for 4 weeks for severe hypertension. I live in constant fear that I'll be fired or my license will be under threat. So I do my best to, and I'll use this word, assimilate, because I know that I can go home and I can feel better when I go home to my family. So I can, they help me feel better. We also heard some examples of nurses feeling that with what they've experienced in the profession, that the relationship is more transactional, which is not what we want, right? We want that intrinsic value to delivering care as nurses. So that transformation to feeling that I'm contributing and I matter, not just as a nurse, but I matter as a Black person or a Hispanic person or Asian Pacific person is important, that we need to reawaken with our nurses of color. At the top right, I've been called the N-word by multiple patients on multiple occasions. The power of nursing is primarily held by middle-aged to old-age white women, and some account of PTSD, unfortunately, with nurses that we've spoken with related to what they've experienced. This is more in examining attitudes, actions, and impact. And the attitudes that we heard was that there's a lot of implicit bias, prejudice, stereotypes, and microaggressions. Actions that they saw was discrimination, oppression, exclusion, insistence on conformity, that's the assimilation piece, and tokenism, which I experienced as well, where I'll be invited to an event that's held by very highly reputable organizations annually, and every time I go, I'm the only person of color in the room. And when pictures are taken of the groups that are put on social media, I have colleagues of mine that would say, there she goes again, they only have this one person. And after a while, it does feel that way. So we have to make sure we have more diversity. So the impact, of course, with all these things, there's inequity, there's self-doubt, there's demoralization, there's spirit murder, invisible workload, right? With the additional work that you have to take on because you are a person of color. Because what we've seen with some of the folks that we've talked to, I complain and I say there's a problem, and then it's, okay, well, then you should take the lead and fix it, and you get no resources, and you feel compelled to fix it, you say yes, and there's more trauma that's related to that. Feeling silenced, feeling invisible, and exhaustion. So we did a survey, that was our qualitative survey where we did listening sessions. We did an actual quantitative survey that indicated, that validated what we were hearing in the qualitative session. So you have the stories that come from the qualitative, but the quantitative puts a number on it. And we know that a lot of our colleagues respond to numbers. So that's why we did that. And we conducted a survey between October 7th and 31st of 2021. And the data that we did get was that over 7 in 10 Black nurses indicate that there's a lot of racism in the workplace compared to white nurses who said that that 3 out of 10 spoke to that existing in the profession. This is more data, and you can see that 92% of Black nurses felt that there is racism in nursing, 73% of Asian Pacific nurses, 69% of Hispanic, and 28% of white nurses. So you see that there's an opportunity here with the 28% and the 92% for there to be some allyship, right? Where there's some storytelling and understanding of what nurses of color are experiencing, so that number that we're seeing with white nurses will increase so that there is action. We also see at the bottom here, it says Black nurses say that they experience racist acts from mostly leaders, which is really concerning, right? So we have some work to do there to make sure that whether it's intentional or unintentional, it's harm that needs to be addressed urgently because of what we're seeing, particularly the attrition that we're seeing in nursing. This is a visual of the report that we just released on racism in nursing, we being the commission, that I invite you all to review. It's a dense read, but take it in bits because there's a lot to absorb in that report. But we also have, with the nursing scopes and standards, where we get to some of the fundamentals around why we do what we do. There's importance for respect and caring, right? Respect is treating someone how they and you would like to be treated, kind of like the golden rule. Caring is also acknowledging and honoring the thoughts, feelings, beliefs, and rights of someone else. Key concepts in the section in the Nursing Scopes and Standards, 4th edition, is the importance of understanding that respect and dignity goes hand in hand, but the backbone to dignity is mattering. And mattering, and we've heard about Black Lives Matter, or White Lives Matter, or Blue Lives Matter. The key thing here, in terms of, regardless of who you put in front of blank matters, the key thing is that these are two complementary psychological experiences, and it boils down to feeling valued and adding value, and also feeling safe. Cultural humility, where there's a commitment to lifelong learning, is never a competency or a test that we do that gets us there. We have to commit to the fact that this is something that we'll have to continue to engage in forever, that we all own, right? It's not just for our white colleagues. Civilized oppression that exists with the social hierarchies that exist, that are occurring, and particularly in the hospital setting, but I'll say overall in healthcare, where as a nursing body, where do nurses feel they sit compared to who has power and influence in the places they deliver care? When you look at nurses, physicians, administrators, and all the other key stakeholders that contribute to care in the healthcare setting, do nurses see themselves as key players and power brokers in that setting to make decisions? And I unfortunately have to tell you that from research that I conducted, and this was a qualitative survey, many nurses did not feel that they had power and influence over decisions in their places where they worked. Inequality and injustice is important to understand as well, that we have covered in this section. Equity falls within a range of ethical values and dilemmas that nurses face on a daily basis. That's that moral distress that you continue, I'm sure you've all seen in the research. Equality, equity, and justice, where equality is about sameness. Equity is really meeting people where they are and really trying to get to a level of fairness. Justice, I read, it was Dr. Cornell West actually that had to say that justice, social justice is love in public, right? Community love in public. And that's what we need to see more of. We throw around diversity, equity, and inclusion, but we need to make sure that we take inventory of why we do what we do and the importance of understanding our roles to dismantle structures and confronting cultural evils. So now we get to the transformation. This is where we get to the upswing, right? Hope, where we can move the dial and get to where our destination of where we want to be as a profession. We have to recognize that some of what we're seeing can be explained in this concept that Dr. Nadia has explained recently in a TED Talk labeled "How to Kill Your Own Company." And she talks about Titanic syndrome that exists with big players, big organizations, kind of like the too big to fail, where, you know, organizations are facing disruption and they refuse to make changes because of the arrogance of always being here. We've weathered many storms, we'll always be here. This is just another one. And the image here is the fact that with the Titanic, we talk about the iceberg a lot, but the iceberg was minding its own business. The Titanic hit the iceberg, even though they had all the tools in place to make sure it didn't happen. One was they had binoculars to see what was ahead that they did not use. They also had a key to a lot of equipment to access tools to be able to see what was ahead that were not accessed. There was an over-reliance on meaningless tasks and a lack of focused energy and a lack of prioritization. There's also a word that with the Titanic, there were operators that were trying to call to send signals, mayday signals to operators on the ship, but the lines were tied up because they were trying to reach their more affluent guests to ask them what they wanted for dinner. The over-reliance on past successes, where you have experts that probably have not seen what we're seeing today, but we rely on them as experts. So they do bring ideas. Some are refreshed, some are not, and we need to pay attention on the voices in the room, to the voices in the room. But most importantly, nurses have to recognize the impact, the potential impact of unconscious bias and practices that contribute to discrimination. And we must actively seek opportunities to promote inclusion of all people in the provision of quality care while eradicating disparities. I also like this visual because it gives you a sense, because we throw words around a lot, right? Words matter. So this is where we distinguish systemic racism, where it is everything. It's structural, it's institutional, it's individual racism. That further has a stronghold on what exists with structural racism, where that's where we find the laws and the policies and the practices and physical structures. And then you have institutional racism with the policies that are at the institutional level that continue to keep people in certain boxes. We've seen that in some dress code policies in institutions as well, particularly in healthcare. No tattoos, and if you have them, cover them up. And there are nurses that have not been hired because of tattoos. Not necessarily because of what the tattoo said, but just the fact that they had them. And then individual racism, where it's the human interaction. Now, as people, we tend to focus a lot more on the individual racism piece, but I say the most important work are at the bars above. We have to address institutional racism, structural and systemic, because they're woven in the fabric. And I want to make sure that there isn't an impression that we're discounting all the other aspects of diversity, because there's so many aspects to discrimination that puts people in a box or prevents their ability to move forward. But we wanted to focus primarily on race because that is the discrimination piece where it's more overt and people see people of different ethnic heritages or backgrounds on site and they judge them and they treat them differently. Some of the others, it takes some time to get there by conversation or getting to know the person. But in terms of race, there are certain names even that where they're not, of people that are not considered for roles because of the names that they carry. So that's why we're really focusing on that piece. And speaking of racism, it's important to understand what's at the center of it. And that's why I took the time to go through the history. The historical legacy still looms large. And around that, you have the dominant culture of power that's causing things to continue to be in place. And then you have the institutional racism that I mentioned earlier, and the personal racism, and the structure that holds it all together that we need to dismantle. We're in an era also of employee activism where employees are requiring their employers to address some of these power dynamics and power distance issues within organizations that actually in some cases leads to civilized oppression, where it is a physician and nurse relationship where nurses are called by their first name, but we have to call physicians Dr. So-and-so. And we have to wonder if it's an organization where we want to level the playing field, where everyone matters, why are we doing that? If we're going to call physicians Dr. So-and-so and they're nurses that have their PhDs and doctorates that are not being referred to as doctor, that's a concern. And if we have to keep the doctor nomenclature for referring to physicians, and we have nurses that are called by their first name, then let's call nurses by their full name, Miss Thomas, Miss Jones, because those, and we don't want those informalities, because it's all about building the team and the interprofessional models, but we have to recognize how the social hierarchy is contributing to the power distance that we see in hospitals. Again, going back to, and in healthcare, going back to the image and perception of nurses and how that's impacting nurses feeling that they have the power that physicians do. And I'm just naming physicians as an example. Diversity, equity, inclusion is thrown around a lot, and diversity is about representation. Equity is about eliminating barriers. Inclusion is really about belonging. And belonging is important to understand, because we know that there's a physical dynamic to not feeling as if you belong or being excluded. So it's important to understand that, you know, we do have, and we saw this during the pandemic, we have a need. It feeds our neural networks for us to feel like we belong. And it's as primary as food and water. And when individuals feel socially rejected or treated unfairly, similar regions in the brain are activated where they experience physical pain. And that goes to the fact that being excluded and not feeling like you belong does have physical implications. Martin Luther King said this in 1966, that all forms of inequality, injustice in healthcare is the most shocking and inhumane. And this continues to be our banner today, unfortunately. This is a saying by Kareem Abdul-Jabbar that he had in the LA Times in 2020, where racism is like dust in the air and it's invisible. And even if you're choking in it, and even if you're choking on it, until you let the sun in, there will be no change. And we have to keep shining the light for us to have a chance of cleaning it up wherever it lands. Comedian Trevor Noah was asked about the difference between racism in America versus racism in South Africa. And he said, well, the difference is, he said, I hate to say this, I prefer racism in South Africa because we saw it coming. The laws were very clear. There were no innuendos where if you apply for a house, they'll say, oh, well, you probably can't get it because of your income. It's really that you can't live here, where here in the US, he said it's more the invisible enemy. There's a lot of what happens with gaslighting, we call it race lighting, where when a person of color does experience racism and they try to explain it to someone who's not of color, there's an explanation. There's always an explanation for why things happen. Anything but racism could be the reason. Really quickly, these are some top 10, this is from our top 10 list of how to be an anti-racist in nursing. And I'm only going to highlight 5 or 6. First one is, which is what we did with our reckoning work with the commission, what was done in South Africa. We have to collect these stories. We have to hear about people's experiences. We can't dishonor their experiences and say that, oh, that happened back then, we don't need to talk about it. People need to reveal their truth. And to hear is to learn and understand why people think the way they do. We also want people to feel that they can be genuine and doing what you say you will do, keeping your word, and making sure that you build trust. And anything outside of that is hypocrisy, and not just doing things on a performative scale. Preserving the dignity of others, where you're not dehumanizing other people. That goes to what I mentioned earlier about mattering, where we have to think about how we can rehumanize people. It's so hard to say that because we're all humans, but that less than compliment that's occurring in certain groups is very real. So rehumanization efforts are very important. And of course, labeling, right? Where labeling is really determining how you treat someone, the implicit bias that you have, where you have different people in a box and how they should be acting, or you expect that they should be acting, or who they are. We have to address those and recognize that we all have them, but we have to make sure that we manage them accordingly. And of course, lastly, and I think this is the last example that I have of this, is exposing unwritten rules of the environment. This is where we get to the structural dismantling and the systemic dismantling of racism. How do you fight what it is you see and how you interpret what you see? And really make sure that we're looking at our policies to make sure that we, the bias that sits in some of those policies are addressed and removed. I think this is the last one. And of course, the authenticity that we all need to be able to have when we come to the table and when we show up, where we can be vulnerable, we can show our differences, and we can be accepted for who we are. I'll go really quickly into what we did with the Partners for Nurse Staffing, because we're there. It's all connected. Nurses' well-being, racism in nursing, and staffing are all interrelated. And it's important to understand that this is also important for us to address the staffing crisis that we're facing today. We have the Partners for Nurse Staffing that's been established since 2017, and this is a group of associations, as you can see from your screen, AACN, IHI, HFMA, and AONL, with the goals to have better patient outcomes, improve patient experiences, build a thriving nurse workforce, and optimizing the value of care. This is a list of individuals of all the folks that participate in the think tank that we assembled from January through March of this year to help with determining what our focus areas should be to help with addressing some of the stopgaps and issues that we're seeing with the nursing workforce, particularly as it relates to attrition. This is a snapshot of what we developed as a think tank in terms of how diversity, equity, and inclusion and belonging efforts can help with addressing some of what we're seeing in nursing, where we're looking at the leadership team. We're looking at trends of underrepresented groups. We're not looking at diversity in aggregate. We're looking at where people are. What's the diversity with folks in lower paid positions versus middle management positions versus C-suite executive positions versus your board? We have to look at those groups differently. And also look at all aspects of the diversity wheel, right? It's gender, LGBTQ, BIPOC, ethnicity, ableism, psych, mental health, substance use, disability. We have to look at all those different pieces to make sure that we truly have a diverse workforce to provide care for the communities that depend on us. We did come up with a racial reckoning statement in June of 2011, and this is where we moved towards our path for transformation, but also taking some sales from what we learned from the reckoning work, particularly with the commission. And the one thing I'll emphasize is that the racial reckoning statement that was developed was solely ANA's work, because ANA decided that, or realized that, it will be hypocritical for us to get involved and work through this commission without recognizing our own ills and what we need to take accountability for. So that's why this is solely the work of ANA, but what led us here was the work from the commission, and what led us to setting up the commission is the murder of George Floyd. So going back to history to come full circle. So we talked about what happened in 1951, where there was a dissolution of 1946, actually, where there was a dissolution of the National Council of Association of Colored Graduate Nurses, and pulling them into ANA, having one association. But in 1970, there was a recognition that Black nurses were not getting what was promised. The concerns that were raised was that Black nurses were not in leadership positions at ANA, and they needed to be more involved with shaping policy. There was persistent tokenism, where certain people were invited all the time and never increased the number. Limited recognition of Black nurses' contributions to the profession, lack of increases in the number of Black registered nurses, no recognition of achievement with awards, other than one award with Mary Mahoney's, and limited appointments of Black nurses. That night, in 1970, was when there was a determination that a new association needed to be formed. So in 1973, the National Black Nurses Association was formed. And it was really about understanding that it's here and now, we have to fix this now, and we're not waiting for ANA anymore, because the promise has been broken. So remember, in 1951, the discussion was, this is a leap of faith. And then in 1973, there was a determination that, yeah, it was a leap of faith, and it wasn't a good one, and we need to create our own association. Fast forward to our reckoning work that we're doing at ANA, on the 50th anniversary of the National Black Nurses Association, we decided to attend their conference to read our reckoning statement to them in person and apologize in person. This room was only supposed to hold 50 people. We crammed 70 people in with the fear of a fire emergency as well. But it was hard to ask people to leave because they so wanted to hear what we had to say. This is an image of all of ANA leaders and other leaders at MBNA that attended the event. That's me in the green dress, Dr. Grant. I'm sure you all unmistakably Dr. Grant. Dr. Dawson, who's the president of MBNA. Next to her in the black and white is Dr. Loretta Cole, our CEO, and Cheryl Peterson, our VP of Nursing Programs. Dr. Debbie Hatmaker, who's our CNO, also attended the event. And we didn't get her in this frame, but she's in a number of other pictures that we have. The lady in the middle in the pantsuit is Dr. Betty Smith-Williams. She's close to 90 years old. And she was there that night in 1973 when there was a determination that the Black Nurse Association needed to be formed. This is a language that we read to the group asking for forgiveness, all the Black nurses in that room, about how that we're really we're offering an apology and we're seeking forgiveness. And we're seeking forgiveness for all the harm that we created and caused. And for healing to concern, we had to do genuine reconciliation and acknowledgement of what we did wrong and asking for forgiveness. So we're actually also saying that this is an initial step. There's a lot more to come to start to right the wrongs. We're not going to be able to right every wrong, but this was a huge step forward in the right direction for us to start to get to some level of transformation. So this all boils down to the positionality that we all face as nurses. Most of us as nurses, we are there as mothers, sisters, daughters, brothers, uncles, aunts, cousins, what have you. And then you layer on top of that our genetic makeup, our background, our ethnic background. You layer on top of that our socioeconomic status and what brought us to the profession in the first place and what's important to us. And when you add all those different pieces, the key thing here is that we need to recognize that we are one body and we need to act like it. Because in a lot of cases, in a lot of instances, in terms of what we found, yes, there are ills in society, but we're seeing too many examples of nurses harming nurses, which is where we really have some work to do. So I'd like to thank you for listening to me. I appreciate your ears and your eyes. And this is the way to contact me if you so choose. And with that, I'll turn it over to my colleagues to continue the discussion. I think we're going to have some time for Q&A, hopefully.
Thank you so much, Katie, for being here today and being able to share this powerful presentation with all of us. We'll go ahead and try to squeeze in a couple of questions. So if you guys can take the time to submit questions in the chat pod, feel free to do so. I will go ahead and get started with this question. What would you say is the most difficult part of implementing a DEI program in a healthcare organization?
Well, that's a great question. So I'll start with this. There are a number of nurses that believe that this is not a real issue. There are a number of nurses that has written ANA since we released our reckoning statement that we're making all this up. We're trying to politicize the profession. We're engaging in wokeism, and they want to cancel their membership. That's the majority of responses that we're getting. So for there to be real change, you have to get people to believe that there's a need for change. And unfortunately, there are a number of nurses that believe that, oh, I treat all my patients the same, so what are we doing here? This discussion does not belong in nursing. That's when I say, first of all, if you are treating every patient the same, that in itself is a problem, because that does not speak to what we need to do for there to be equity in providing care, because all patients are different. Their needs are different, and the way to meet those needs, those strategies have to be different as well.
Definitely, 100% agree with that. Looks like we have a question here from Myla asking, what resources can we provide others that are experiencing this?
So in terms of DEI efforts, so first, I think what would help is sharing the data that we have and the stories that we have. And we have that available for free on our webpage. So nursingworld.org has all of those resources. So I think that would be a start, and let that our process and our methodology drive yours as well, where you are asking overall in your institutions where you work, what's the perception of racism, bias, discrimination? How much do they feel it exists, not just in terms of how we deliver care, but how we interact with each other as healthcare providers and deliverers and professionals? I think that is a good start because people respond to data. But when it comes to implementing change, I always use a framework from the Heath brothers, where it's the elephant, it's the path, and it's the rider. The rider, R-I-D-E-R, is a person sitting on the elephant. The elephant is the emotion, and the path is the process. The biggest piece that could impact change in that illustration is the elephant, and you have to get to the emotion. And how you get to the emotion is what I mentioned earlier with storytelling. You have to capture these stories. And we have to make sure that these stories really help people see what we need to see in terms of how we're not separate from what we're seeing in society, to help with getting to the process and stimulating brains with data.
Thank you. We'll go ahead and take one last question. You might have touched on this a bit, but Laniti is asking, how can RNs work together to support health equity efforts, such as the development of learning health systems?
Yeah, it needs to be, the strategy needs to be to start and sit in strategic plans, right? And strategic plans usually last, it used to be 5 years, but I think because of how dynamic our environment is, it's a 3-year document. It starts with a strategic plan. And when it's in the strategic plan, funding follows. And then there are key results that have to be measured and monitored. And then there's ownership around the organization, where not just nurses, everyone has a piece of moving the dial. But the key is for us to make sure that we diversify our workforce. We're not diverse enough. We have too many institutions that deliver care that have people that were within those, that sought care within those institutions, that have long memories. And a lot of those folks are still alive. They saw what they saw during the civil rights era. They saw that they had to go through the back door to enter the hospital. They saw their loved ones that was in for an emergency, and then they had to go, the providers left their mother or father or grandmothers because a white patient came in through the door and they lost their loved one. So there's a lot of long memories in communities where healthcare institutions sit. And there's a lot also that I would like to offer to everyone, that the health disparities exist within the zip codes where a lot of these institutions are. And the disparity, there was a visual that I saw in Philadelphia, which was one of the more left-leaning communities or cities that is. And what we found was that the community that sits where the main hospital, University Hospital is, had lower life expectancy compared to the zip codes where the Liberty Bell was, which is a more affluent neighborhood. So that is part of what we need to pay attention to. What's under our feet to help move the dial in terms of health equity, because it's the opportunities are all around us, and we all need to engage and lock arms and owning a piece of this, because we've managed it as a project with case management teams and things like that, and we can't do that anymore. People are dying.
Thank you. The rest of the questions we'll go ahead and email over to you, Katie, and then send those out back to all of the attendees. But that is it for the Q&A portion. I'll go ahead and turn back over to Michelle for any closing remarks. Thank you.
Thank you so much, Ashley, for facilitating that Q&A, and for Dr. Katie Boston-Leary. We are so honored and privileged to have you here today. This topic is so important to us, and we appreciate learning from you. For registered nurses that are seeking CE credit, you will receive 1 CE credit upon completion of the evaluation that we will send out in an email after this event. So please be watching for that, and we hope that you can join us for future leadership webinars. Thank you so much.